I can't tell you what a pleasure it is to introduce Dr. Guilfoy, our speaker tonight. They say that in order to be an expert, you have to be 50 miles from home, you have to wear a tie, and you have to have an accent. And Dr. Guilfoy is none of those except for the expert. I have patients all the time say, I got this orthopedic problem, where should I go? Think I'm going to say, go down to Sacramento, go to San Francisco. I say, go around the corner and see the best guy around. As I said in the announcement, Dr. Guilfoy has taken care of my family for decades. The only orthopedic person that we have used. I just have terrific confidence in him. And under his leadership, he's put together an amazing team at Folsom Orthopaedics. He has a younger guy, everybody's young compared to me, named Sean Walquist, who is, I think, an exceptional surgeon, but I am not kidding you. Everybody that has seen him comes in and they go out of their way to say what a nice guy he is. I mean, he's got that personality. People love him, and they love the surgeries. And he's got a couple of other people in the office that have been with him for decades. When you know that people have been together for decades, something good is happening in the office. A woman named Terry Pavelko, who was a PT before she became a physician's assistant, and a woman named Misty, I don't know Misty's last name, but she was our first contact when my son had his orthopedic issue and went in. And again, he's put together just an amazing team, well-run office, great service, no bull. I think that if you have an orthopedic need, there's no need to leave town. You go around the corner and see the expert. As you will probably pick up, I think that Dr. Guilfoy is kind of a live wire himself. We have mutual friends, and I know I've heard many stories about how many times he himself has been on the orthopedic operating table, so he knows both sides of the equation, because I think he's a little bit of a wild man. But when you come to descriptions, I think the description would be hot as a pistol, but cool inside. And I think that's the kind of person you want on the captain of your team when you've got something that's important to your life. Again, I think he's the man. So we're just delighted to have you. Thank you so much, and it's all yours.
All right. Well, thank you, Tim. We've known each other a long time, and I don't know who you were talking about, but yeah. Very kind words. And yes, I do have an amazing staff. They've been with me 20 to 30 years, a lot of them. So they're more than helpful and go out of their way for you. So we're going to be talking about total joint arthroplasty, and I've been here a while. Some of the pictures put together by my staff, so apologize for that. But I'm with Folsom Orthopaedics, and I've been in Folsom since 1992. I separated from Mather Air Force Base. I was in the Air Force for 13 years. I've practiced in Folsom. I've been a founder of the Folsom Surgery Center in 2001. I've been the co-founder and the chairman of the board at West Coast Joint and Spine, where we do a lot of spine surgery and a lot of total joint surgery. And since I've been in Folsom, I've got somewhere around 15,000 surgeries, plus or minus. Starting out in Folsom a long time ago, I'm kind of what you call a dinosaur in the orthopedic. I've done everything in orthopedics. I didn't do a subspecialty, I kind of did everything. When I got here to Folsom, we didn't have a lot of subspecialists. Treated hands, I treated feet, did total joints, I did a lot of sports medicine, been out in the field many times with the Bulldogs, treated a lot of pediatrics, and time has gone by. So, as my practice grew, I took care of a lot of people, a lot of young families, these guys with, the dark hair, 5% body fat, took care of a lot of those people, and unfortunately, they're all looking like these guys right now. And that turkey bowl up there in the upper right-hand corner, that's always great every Thanksgiving. I can always count on business from that. But everybody wants to keep active. We got a very active community, and so they want to keep active. That's the best thing you can do for your joints. But things wear out. Is your life coming to an end when you have to have a total joint? People come in and they go, oh my God, I'm not that old. I can't do it. I don't want to do it. Your life doesn't come to an end. You can do a lot of things with a total joint. And there's a lot of things to be scared of or frightened about that you hear on the internet. You all know somebody that had some kind of disaster. Fortunately, that's not the case. A lot of people do exceptionally well. Highest percentage do exceptionally well. So, patient with me, I'm not a AV kind of person here. Total joint replacement. My practice has now evolved. I did sports medicine. I was on call for the emergency room for 30 years. I stopped the ER call about 3 years ago. I did a lot of arthroscopy, reconstructions. But now my practice has evolved in the last 7 to 8 years. I'm doing 75 to 85% of my practice is joint replacement or leading up to joint replacement. So we're going to talk about the steps in that. It's not so much, I'm not going to dwell specifically on procedures. I'm going to give you kind of general idea. What do you do prior to surgery? How does the decision process come along? What am I looking at? What do I expect? What's going to happen on the day of surgery, the procedure, what's the success of them? And then post-operative treatments. Probably one of the most important. How you're going to handle it post-op is how you're going to get that result you want. So we'll be going through kind of those steps. So the decision process. When do you decide on that total joint? When do you decide on that time you say, oh man, I'm not 30 years old anymore. My joints aren't making it. It's a process. The joint itself is to decrease your pain and improve your function. Doesn't say restore all your motion, and it's not going to make you feel 30 years old. It's there to make you comfortable, so you're not thinking about that pain. You're not restricting yourself from the activities you want to do. That's the goal of a total joint. Some of our biggest challenges now is everybody wants more out of that joint because everybody's active in our community. It's quite an active community. And they have to understand there's some restrictions. But what do you do leading up to it? How do you prevent this thing from happening? And that's the number one thing you guys all want to do. So, number one, try to maintain your motion, your flexibility, whether it's Pilates, yoga, working with a trainer for stretching. Motion is the number one thing. You kind of think of it like a rusty joint. As the joints get old, they get a little bit more rusty looking. They aren't as smooth, they aren't that Teflon surface. If you move that joint, it's like a gate. If it's rusty and you don't move it at all, it gets stiffer and stiffer and stiffer. If you walk through that every day, it goes through pretty easy. Same with your joints. They lubricate themselves by movement. That's how the inner lining of the joint works. Movement lubricates it. So, range of motion. If you're losing motion, can't seem to work it, physical therapy to get that motion. I was asked earlier, what's the best thing to do if you need to prepare? Well, if you got great motion before you have a total joint, that's good. If you don't, best you can do beforehand is try and restore that joint as much as possible in that motion. That'll give you the best result. Regular exercise, low impact. You got a bad joint, keep on cycling, keep on walking as much as you can. Elliptical, weight training, keep it moving as much as possible. Extra strength Tylenol works wonders if you use it right. If you're trying to catch up, it's not going to work. Motrin, ibuprofen, naproxen, Celebrex, meloxicam, all non-steroidal anti-inflammatories. if you go and do something and it sets it off, and then you try and catch up, it doesn't work as well. So I tell people, you know, if you're going to be doing something that you know is going to bother that joint, like on a Wednesday morning, if you know you're going to do 4 total joints and you take those 3 Motrin, as somebody did this morning, gets you through the day. You take it beforehand. It keeps that joint from getting inflamed, keeps it from swelling up, and so you're not playing catch up. And I've had people go a long time without surgery by doing that simple thing. You know, that first day of scan, I take the whole 4 Motrin before I go up there, you know. But steroid injections. Steroids have their place. Sometimes we use them diagnostic to see if it really is the joint that's bothering you. If you're going on vacation and you're waiting for that joint, we'll do a steroid injection and get you comfortable. If you have a steroid injection, you won't be having a joint done for about 8 weeks because it changes some of the dynamics in the joint. We don't maintain regular steroid injections. Multiple steroid injections can actually start to break down the cartilage. It can soften some of the tissue, maybe ligament tears, a number of things. So we don't maintain it with steroids. Now, they feel great. You get a steroid injection, you get that energy, you go home, you clean the house all night. Sometimes that happens. But we're not going to keep doing that. We're going to have a limit on how many you can do of that. PRP, platelet-rich plasma. Platelet-rich plasma is we draw blood out, we spin it down and concentrate it. We've been doing it over 20 years. And we concentrate the platelets in that plasma. And it has a certain amount of proteins in it that stimulate your growth hormones, your cytokines, your stem cells. It stimulates those as a reparative stage. Does it work for joints? Not that well. You're going to be paying cash for this, so think about it before you have it done. The prices on this can range anywhere from $500 to $1,500, depending on where you are, or even $2,000. We've heard $2,000 in a few places. It works great for tendons, tendonitis, patella tendons, Achilles tendons, but your joint is turned to granite. It's 2 granite slabs rubbing against each other. It doesn't really repair that. So PRP, it's a plus or minus. I have patients that try it. I tend to use the combination of the bottom 2 on some of my 40-year-olds that are worn out. They still have some potential to kind of get there, but it's an expense. The bottom one, hyaluronic acid, visco supplement, rooster juice, as some have called it. The reason it's called that, it was originally derived from a rooster comb. That's how they figured out there's hyaluronic acid in that. Hyaluronic acid is what's in your knee. It's what produces the lubrication. And these injections have worked. They're about 70, 75, 80% successful if it's not too worn. Insurance don't want to pay for it anymore. So a lot of insurances aren't paying for it. That is going to be a cash pay. That the series, some of them are 2 injections once a week for 2 weeks. Some are 3 injections once a week for 3 weeks. They're about $500 for the series. I do have some people that have used this pretty regularly. Our office, we must do somewhere between 200 or 300 of these injections a year. And people do well till they don't. So same with the steroids. You get 1 or 2 injections and you'll do well until you don't. Then we're going to be talking a little more seriously. So we kind of went through everything you can do beforehand. And you work on them, and you're doing all right. And then at one point, you get to that point that you go, you're thinking about this thing every day. Starting to get worn down. You feel kind of more tired when you do things, and it's just that nagging discomfort. And you're kind of limited. You stop doing things. You know, you're not going to go walk with the kids. You're not going to walk the dog. You're not going to do some of the things you want to do because that joint, well, today is not feeling too good. So my job, I'm never going to tell anybody, you need to have a joint. I'll tell them your next surgery will be a joint. But when you go through all these and you get to those last two questions there, you're going to come to me and say, I want it tomorrow. Unfortunately, we're booked out 6 months, so you're going to have to wait and we'll have to work you through it. But that's the deal. Your surgeon isn't going to tell you you have to have it. You're going to make that decision. That's the best way that you're going to get your best result. When you realize those expectations are kind of not being met by non-operative treatment. So, prior to surgery, what does that involve? You make that decision. We start all the paperwork. We start the clearances. We start the authorizations with insurance. We start the scheduling. You're going to have to visit your primary care. They're going to give us a clearance, checking your heart, your lungs, lab work, checking your medications, make sure they're all tuned up where they're supposed to be, your blood sugars are good, your blood pressure's under control. You're going to see your dentist and get a clearance from him. What's the deal with this guy? No, I don't have any dentists in the family. But the theory is in the first year after you have a joint, that joint has a lot of blood supply going to it. And that blood supply, when you have dental work done, you get a little bacteria in your bloodstream all the time. Dental cleanings, anything else. And the idea is that your body takes care of that. If that bacteria latches onto these metal pieces, they form a barrier. And antibiotics won't penetrate that. So that's why in the first year, as that joint's incorporating into the bone, we have you take an antibiotic. And it's a one dose, usually ampicillin or amoxicillin, and it's usually 4 tablets, 1 hour prior to the procedure, and that's it. After the first year, you don't have to have that. But that's kind of a standard practice in the first year. Also, if you've got real bad, gingival disease or you got an infection in there, we don't want to do the surgery till that's taken care of. I know Kaiser is very strict on their dental prophylactics. So, cardiology. Cardiology is usually the hang-up. That's the hardest to get cleared from. It can take 2 months to get that cardiologist to clear you to even get in to see him. So if you're planning on this, sometimes see your cardiologist early, get that clearance earlier, tell them you're planning on having that, then they will just check it off for you. It's wise to discuss metal allergies, specifically nickel. Some of these are cobalt chrome. They do have nickel in them. It's theoretical that that could cause some inflammation in a joint. If somebody has a severe reaction, they say they've worn some cheap earrings and their whole face blows up, we may change and do a different prosthesis than one of the ones up here that we would normally use that has some nickel in it. That has never been really proven. It's more of a theoretical possibility of problems with total joints, with chronic pain or swelling. So it's advisable to discuss that with your surgeon. Lab work, we'll get clearances on all your blood work, your liver, your diabetic workups. And some of these, there's a time constraint too. EKGs, chest x-rays may be good for 6 months. A lot of the lab work, that has to be done within 30 days. A lot of the clearances have to be done within 30 days. Requirements at the hospital or the surgery center so those are all things to think about prior to decide on the surgery, because a lot of surgeons are backed out. And if you're waiting for that and you have to get these clearances, you have to wait if something comes up. I have people all the time asking if they can be moved up on a list. If they haven't gotten these done, they can't. So, your next choice. Where are you going to go? You're going to go to an outpatient center, go home the same day. Usually the total hips and knees will go home 2 to 3 hours afterwards. The shoulders, they usually go home 1 to 2 hours afterwards. Outpatient centers will get you up an hour and a half after surgery, start walking on it. If you have stairs at home, they'll help you up and down instead of stairs to know you know how to do it. It's really quite remarkable. When I first started here, when I first started the West Coast Outpatient Center up the hill, that was just 6 years ago. The general across the country was about 20% of your patients are going to qualify for outpatient. Our population here is about 75 to 80%. Very active, young, mobile people, and they're going through, majority by and for are going to the outpatient center. When do you go to the hospital? You're going to be done in the hospital. Well, it's medical issues. Okay, you've had cardiac problems, heart problems, you've had anesthesia problems. Weight can be a factor in that there's limitations on some of the outpatient centers. So there's different things that your physician should decide, are you appropriate for there? And if you're just not comfortable going to an outpatient center, you want to stay overnight, you go to the hospital. If you don't have anybody really to help you at home and you plan on going to a rehab center, generally you go to the hospital so you can get qualification for your insurance to pay for that outpatient or for that rehab center. So sometimes for Medicare, that may require a 3-night stay in the hospital. That's pretty much the only reason I keep people in the hospital, for that 3-night stay, and if they're going to go to a rehab so that they can qualify for that with their insurance. So, time for surgery. You're going to have a total hip replacement. So this side right here is an example of different total hips. A lot of these aren't pertinent because they would be more complex cases or revisions of problem cases. This is one of the prosthesis. Be careful with this is ceramic, don't drop it. The plastic, and don't try and put the plastic in here because it won't come out. So don't put it in the cup. So you can go ahead and pass it around.
Okay.
The head of that will come off, so be careful with it. My rep that I used, I've known him for 33 years, and I told him I needed some props. He gave me his set here. He was an airman at the Air Force Base when I started there, so, which is kind of frightening. It's been that long. So total hip arthroplasty. These components are metal. There's a high-density plastic liner that you'll see there. There's a ceramic head usually. Sometimes it'll be a metal head. Metal heads may tend to be cobalt chrome. The majority of them are usually a titanium. Titanium has a little more flex, a little more response in the bone. There's some variations on the equipment we use. This is kind of a standard one here. There's different ones we use with more mobile balls and cups. If you've had a fusion, like the gentleman on your right, lower back fusion, we use a different kind of cup to increase multiple directions of mobility. It decreases risk of dislocation because you've lost some of that movement in your pelvis. These hips are both destroyed. The one on the right, you can see the difference from the one on the left. This one over here is seriously destroyed. And the other thing that hips can do is they can mimic things. I get people come in, complain of their knee. They know it's their knee. We look at their knee, it's not their knee, it's their hip. They can walk. You can walk with a hip by taking it up in your back, your knee. It can be very stiff and you don't even notice it. So that's part of an evaluation because a hip can refer down to the knee. It can cause pain up in the back. So deciding if that's the etiology or that's the reason for it is very important. Regional blocks, not so much on the hip. I don't do spinals. Some of the spinals have had other complications that have actually delayed people leaving more than the total hip did. So I don't tend to use them. Femoral blocks, some people will use a femoral block on a hip. I don't tend to use those mainly because there's a little more trouble controlling a leg. Some people use them quite well. I just don't have a need to. The total hips do quite well.
So what do you use
This is usually general anesthesia for the hip. Yep. The total hip arthroplasty usually takes about an hour and 15 minutes, plus or minus 15 minutes. It may be less than an hour, or maybe an hour and a half, depending on how complex it is. By the time you're in and out, it's about 2 hours in the surgery suite. There's basically 4 different approaches. The direct anterior has been very popular over the last 8 to 10 years. It's advertised a lot. Then there's an anterior, which is called a Watson-Jones. There's a lateral, and then there's a posterior. They all have their pluses and minuses. There's complications with each of them. There's positives with each of them. Bottom line is, if your surgeon has been doing a lot of joints, they're comfortable with what they do, and of course, Tim drops it. So, if your surgeon's been, experienced, he does a lot of joints, doesn't matter which way he does it, 6 to 12 months, you're going to have the exact same outcome, whether you do any of these approaches. So, the realities, the most important thing is surgeons that does a large volume, comfortable with total joints, and the approach they use, that's what you want.
So what do you use?
I do the Watson-Jones and anterior. I've done anterior my whole career. And the positives I have on that is there is a slightly lower dislocation rate. People get up, they move around pretty quick, and they have less precautions post-operatively. So, shoulders wearing out. The hip was one that people ignored for a long time. They're making it up with other things. They're walking kind of funny. People keep saying, "Are you limping?" I limp. I haven't had a joint replacement. I've had multiple other surgeries, as Tim mentioned, but people keep telling them they limp. Oh, no, everything's fine. Shoulder is the one people ignore the most because they can get by pretty well with this movement. So they tend to get very stiff before they get done. There's basically 2 standard classes. There's a standard, which is an anatomic, where the ball is on the ball side, and there's a cup. There's a plastic liner right here. That's that dark area there where there doesn't one. There's a plastic liner there. That's a standard. For that, the rotator cuff really has to function well. Then the newer is the reverse. That's where we put the ball on the cup side and the cup on the ball side. This changes for not just if your rotator cuff doesn't work, it changes some of the mechanics of other muscles to use it. This has been in the early 2000s. This was minimally done. It was kind of first introduced. You only did it if that was the very end and people had to be over 80 to do it. Now it's progressed to where a lot of them are the primary joint that's being put in. Main reason is how many people have partial rotator cuff tears after 50? A lot of them. And when they got arthritis like that, they definitely have some partial. So putting the reverse in tends to spare that because when the rotator cuff goes out, the standard doesn't work quite as well. So this is some parts to the shoulder. This is a reverse, and there goes a part. This is a reverse ball on there. This is a standard ball. This one, the plastic's in there. The other one, don't shove it in there. It's not going to come out. So, the shoulders, we do blocks on those. We do a scalene block, which really keeps people very, very comfortable. So this is the block. They'll do the block up in here. We also do a local in the shoulders. We do a local in the hips. We do a local in the knees. We do give you a medication that manufacturer says it's 72 hours. Well, it's not. It covers about 24 to 36, maybe if you're lucky, 48. But that, in addition to the block, people are very comfortable right after surgery. And it makes you more comfortable in getting started in your movement. The block takes about 5-10 minutes. Total knee replacement. So total knee replacement, a lot of the prostheses are cobalt chrome. They're, more of them are cemented than they are in hips. In fact, I haven't cemented a hip in decades. Total shoulders, sometimes the cup side will have a little cement, but most of the time we don't have cement in them. The total knees, some will cement them, some won't cement them, some will do one part cemented, one part not cemented. It's really surgeon preference for different reasons. They're made out of cobalt chrome, standard. Sometimes if you have a metal allergy, you'll get an ingrowth one, which is titanium, or you'll get a coated one, which is pretty freaking cool looking. I mean, it's covered in molybdenum, which looks like gold. It's pretty cool. But I have to order that early. So the total knee prosthesis, the femur side, as you see, it's 9 millimeters thick. I'm not ripping out the whole end of your bone. I'm basically resurfacing the end of your bone. The tibial side, we cut 9 millimeters. Put a plastic liner in it. Remember, it stays in the metal if you push it in. So there's a plastic liner underneath the kneecap for the knee. And initially when they're put in, that's cut, the soft tissues are cleared around it, tend to have a click underneath that kneecap when you're bending it. And that's a very typical question. That thing clicks. The majority of them, soft tissue eventually grows up around that plastic piece, and that clicking goes away. But it's a metal piece and a plastic piece every time you bend your knee. So there can be a click. It's not hurting the prosthesis. It can be cemented, non-cemented. Do you use a robot or not a robot? We have up at West Coast, we have 2 different robots. One's a Mako, and what's the other one called? A Velis, the Velis. I don't use either of them, but we do have surgeons that use those on a regular basis. A lot of them, well, most of them, well, all of them are younger than me. So they had it in training, they're used to those. I use a computer, and I use a computer, and it's a movement that we use that identifies the position of the femur part. And the rest of it, after I make those cuts, join on. So we're all using probably some kind of computer. This is preoperatively, I put a template up, we kind of plan out the size that we're going to have, what our cuts are going to be. This is a computer setup. You see it up on the wall on the back there. These are some of the angles that are being dialed in. We do blocks for total knees. An adductor block in the thigh here. It's paramount to get you good, comfortable, so you can move that knee right afterwards. Very helpful. And we also do that local in there. Sounds like another one went to the ground, huh?
And how long do those blocks work? Those are the kind that have slow release over 5 days?
The blocks?
Yeah.
The blocks usually will only be anywhere from 6 hours to theoretically 72. Most of them are going to be 24 to 36. The medication comes off faster than the manufacturer says it's supposed to. But when you have any of these, you have blocks, you can have local in the joint. We give you a combination of medications. And that combination, it's important that you start that on kind of a regular basis at first, because it's the same as the anti-inflammatories beforehand. If you can keep ahead of the pain beforehand so you're not playing catch up, the medications work very, very well. So this is a block, regional block, for the total knee. Total knee, I didn't tell you, the total shoulder, that usually, the surgery is somewhere between hour and 15 minutes to maybe about an hour and 30 minutes. By the time you get set up in there, you have a block, it'll be easily 2.5 hours in the surgery suite. But the surgery itself, usually about an hour and a half maybe. Total knee, it's also about an hour and 15 minutes, maybe an hour, maybe an hour and a half, depending on how complex it is. By the time you're in there, you have your block, it's about 2 hours. So that's pretty much the procedures. Any other questions on those procedures?
Is there any credibility to a good timing in one's life, say age-wise and such, to have a maximum successful surgery and results?
Well, I've operated up through the mid-90s. Some people I've had to replace some joints on 40-year-olds. Does one do better than the other? Well, actually, the older you are, they seem to tolerate this procedure a lot better than the youngsters do. But there isn't any one optimal age. It's basically that criteria. When you reach that point that you aren't doing what you want to do, when you're thinking about it every day and it's draining you emotionally, you're going to say, I'm done. And if you're 50 or if you're 90, that's the time to get it done. We'll get you through with the rehab and the medications. We'll get you through it. So.
What are the best, I'm going to need replacement in 6 months.
With the what?
I'm going to need replacement in 6 months. So during that 6-month period, what are the best things to prepare and get the knee ready for that surgery as far as exercise?
The best things to do, we're going to kind of go over that here, on what you want to do after surgery. So I'll hit each one of them, the best thing to do to get your best result. Do we have another question?
Weight limitations, body weight limitations?
Body weight is limited, has limitations, and I believe Kaiser is, the body weight is off your BMI, which is, I think their restriction is 40, could be 35. I do larger ones, mainly with the idea there is a higher risk of complications by body weight. There can be a significant. And the philosophy is there still is people that get well with those. You just have to be able to accept those complications and be ready to deal with those as a surgeon, how I'm going to fix them when they do arise. Because they do have a higher.
Doesn't tend to wear the joint,
Doesn't wear the joint out more.
I can remember them not allowing it to be done because they would wear the joint out.
The joints, no, the joints do quite well. We used to tell people they're about 8 to 10 years, that plastic in them would wear. The newer plastics now in the last 25 years, they're going 18 to 20 years. I have people walk in that I put their hip in 25 years ago, which some of my staff just love to tell me that that was before they were born. But, you know, but I'm amazed at how long these things are going now. Do you have another question?
Yeah, I did have a question. I have a couple of friends who've talked about a kinematic knee.
Mm-hmm.
And I'm wondering if you could describe what that is, that approach to aligning
Right.
the replacement, what that is, and do you use that? And if so or not, why or why not?
So the kinematic, the anatomic comes down to you have a normal curvature out to the side, which is a standard for most people. And we can make the anatomic, we try and make those cuts so it sits in that standard. The kinematic has come along more that you have a joint that's cattywampus and make the cuts so it evens out when you're bending it, when you're extending it, with the assumption that your ligaments have changed, everything's changed. There's positives, there's negatives. There's one there. If you go to an orthopedic conference, these guys get at each other all the time. You know, that's crazy. This isn't. That's crazy. You're old, stuck in your ways. The fact is, now we use a lot more balancing, and I make some cuts. I make the initial cuts along kind of standard line, but then I use a balancer, and I tension it to balance it out so that it's balanced as it moves with all the ligaments. Is it a crossbreed? It's a crossbreed. Yeah, between the two. But that's the difference. Kinematic kind of takes the anatomy you've got at this stage, and they just make the cuts and replace it. So the X-ray may not look beautiful as far as our standard of a anatomic, but it works quite well. So there's proponents that think that's the only way. There's proponents that think the anatomic is the only way. And I think it's a cross between the two. You want the thing to be balanced in extension and flexion. That's your best results.
Does scoliosis make a difference in the alignment of the knee?
The what? What was that?
Does scoliosis make a difference in the alignment of the knee or head?
Yeah, that's a good question, especially with the hips, because people will come in thinking one's hip higher than the other. 9 times out of 10, it's the scoliosis that becomes more evident because the hip doesn't hurt anymore, and they're not walking with that. And it doesn't really change the prosthesis I put in, nor with the knee. So.
My doctor mentioned a Jiffy knee,
A Jiffy knee?
and you can find it on the internet. And it's mostly doctors in small towns that are doing this. I think it's probably a gimmick, but they're saying they don't cut any muscles or tendons. So they're saying instead of cutting those, they move them aside with a special clamp. And so the recovery is much better.
You got to cut something to get in there. You got to cut something, and usually there's not much muscle. You kind of split up above one of the ligaments. Some of the problems they had when they did the minimally invasive knees is they did small incisions on the side, put them in. Problem with those is there was a significant amount of malpositioning of the prosthesis, and if it's really out of position, it's not going to work. The Jiffy, I'm not quite certain it's going to be his approach through the knee. It's still going to be cutting bone and realigning things. So I'm not certain what exactly they're referring to. If it's the minimally invasive, there is one where you can lift part of the muscle up, and theoretically it can come along quicker. It can be hard to get good alignment, though.
How do you know if your prosthesis is wearing out? And if it is, what do you do to fix it?
So if the prosthesis is wearing out, generally you've had a good functioning knee and you start having some discomfort. And number one thing is we test for any infection. We do lab work. We may draw fluid out, x-rays to see if there's asymmetric wear. If the assumption comes down, I have a gentleman that I put in 2011, and he's been a hiker. He's been for years. He's in. His knee's swelling up some. He's never had any problem with it. All the other tests for the problems with it have been negative. He has the plastics worn. The plastic is worn. And so we'll get into that shortly here. So what do you do right after surgery, immediately post-op? So ice to the joint, 20 to 30 minutes every 2 hours. Don't leave it on continuously because you'll get a reflex on that and it starts to swell up from it. So ice on, ice off. Some people love the coolers. They carry the coolers themselves. You fill them with ice. It circulates it. They work quite well. The problem with it, somebody has to carry that cooler over and fill it up with ice, and you're not going anywhere because you're not going to carry that cooler around. There's also others where it's a wrap that we put it on that you get little packets that you can put in the refrigerator. You can put one on to cool it, leave one in the fridge, the freezer, put that one on later. And that's more mobility. It comes down to what your choice is, what your surgeon's choice is, which of those you're going to end up with. Medications. We're going to get into the cocktails that we're doing now, and they're pain cocktails, what they're called. It's a combination of medications to control it. A lot of them are not narcotic. The goal is to minimize narcotics so we can get you moving. The thing is, you take them on a regular basis. As soon as you start feeling discomfort, you start that medication because I can tell you the block's wearing off. The pain's not going to go away. So if you feel great, you start feeling anything, you take the medication. What's a pain cocktail? There's a combination of medications. It's pretty standard for all surgeons to use some kind of combination of them. There are some narcotics. Tramadol is one we use. It's a very mild narcotic, and it's actually been my number one line, along with Tylenol and the tramadol. There's some medications that you can't that will counteract with what you have. So we don't give that then. Oxycodone, Norco, Percocet. The tramadol is 1/5 of those other medications, so it's a minimal amount of narcotic. I do give some breakthrough tablets, usually oxycodone for me, and it's about 10 tablets. If you're not getting that pain covered, you have a little stronger one, but we don't use much in the way of strong narcotics. Some others for nerve pain, people keep them very comfortable. One's gabapentin or Lyrica. I use it at about 7 days. Most people don't need it after that. Some just don't use it. And I have some people that don't want to take the narcotics, but they need a little bit more after that first 7 days. I'll give them this before I'll give them a narcotic. Anti-inflammatories, we use Celebrex, meloxicam. Blood clots, prophylactic. The standard really is aspirin. 81 milligrams twice a day for a month. Getting up, moving around is the best thing you can do to avoid that. Avoid high altitude, no plane flights for the first couple of weeks to decrease that risk. If you've been on any other previous blood thinners for blood clots, then we'd usually start you on that one that you had in the past. But it's usually about 30 days that we use that, 1 month.
I have a question.
Yeah.
The first pain med, the 4 that you listed, I missed what you said. They are used together or not used together?
The tramadol, all those 4? Usually you're going to get one.
Just one.
The tramadol is my usual standard. That's 1/5 of everything else. But some people can't take it because of other medications they're taking. Very few are allergic to it. In that case, it's one of those other medications that I would use. But it'd be just one of those, might be one of the nerve pain, and probably one of the anti-inflammatories.
What if a patient has found an effective time of usage in another surgery of one of those?
If one's been effective,
Yeah.
we can use those. But with the blocks, generally this is the combination we use.
Right. I mean, for instance, if they found Percocet was more effective than tramadol in the past.
I mean, we can do that, but I generally keep away from the stronger narcotics, unless there's a specific reason that you can't. So, Doc, what are you doing? You're ripping my whole joint out, and you're not going to give me anything. You'll be surprised. You'll be surprised. I've had people come in and they never took this stuff. So, well, the road to recovery, general for all the totals, shoulders, hips, knees. Movement, get the motion going as soon as you can. Shoulders may be a little more restrictive. We'll probably have a sling. Most likely, I like to start pendulum exercises the day or the next day. And that's basically you're just leaning over, watching the news, you're letting your arm out of the sling, let it hang, and back in the sling. Shoulders may be in the sling and immobilized a little longer, 4 to 6 weeks. Soft tissue mobilization, this is where somebody else, physical therapy, can be helpful. They'll work those soft tissues, get that swelling down. Mobilizing that tissue is the best thing to get the swelling out and to get your motion back. I had a major surgery on my shoulder after a motorcycle crash. 2 plates, 16 screws. I went into the therapist 2 weeks later. She didn't really want to do it because the scar was looking pretty scary for her. But it helped immensely getting my motion back in my shoulder. Dental prophylactics for the first year. We talked about the dental prophylactic. Elevation of that joint, that part. Walking in a pool when the wounds are healed, that's outstanding for hips, knees. And then starting physical therapy, I prefer to have people try and start in 3 to 5 days. 7 days is really kind of important to get yourself comfortable that joint can move and get the motion going.
Did you say the shoulder, though, is a little later than the other?
It's a little later. We start the pendulum exercises, but I don't have them moving them too much. So that's unique. So the road to recovery, the hip. You can progress weight bearing on it as you can, as much as possible. I have people walk in 10 to 14 days out. They're not bringing a walker. They don't have a cane. And so you can progress with these pretty well sometimes. Balance is the most important, working on your balance. having a therapist work with you to keep your gait going normally. Restrictions, if you have a restriction on your direction, depending on anterior, posterior approach, usually about 2 to 3 months for those restrictions. An anterior approach, no lunges, no hyperextension of that hip, because I come in from the front. You don't want it coming out the front. So those are the main restrictions. Can you sit 90 degrees with your leg? You can. Can they be crossed sometimes? They can. Posterior approach, the restriction is the hip is don't flex it up more than 90 degrees. Keep it less than 90 degrees. So don't really want you crossing your legs, do any kind of a squat or anything like that. Therapy, I usually go 4 to 8 weeks. Some people go longer with that to try and restore your gait. The results, total hip replacement, people get outstanding relief with these. One of my favorites. General activity is about 6 weeks. I've had people play tournament golf in 6 weeks in a cart, but yeah. You're going to be walking, cycling, weights, swimming. You could probably start that around 6 weeks. More competitive high activities is going to be 10 to 12 weeks out. And those are going to be the pickleball, doubles tennis, dancing, skiing. You'll see improvement over 3 to 9 months. So these are processes. It takes a while to get there. Second one, the shoulder. That's the second best as far as alleviating pain. It does an excellent job. The sling and the standard shoulder is about 4 to 6 weeks. The reverse total shoulder, some you may not require a sling at all. Some may require a sling. That depends on the surgical technique that your surgeon does, whether he'll want you to wear a sling. I tend to use a sling for about 4 weeks afterwards. The pendulum exercises I talked about. And starting anywhere from day 1 to day 14 for those pendulum exercises, I like day 1. If you had a stiff shoulder, physical therapy is very helpful. And that can take 4 to 12 weeks sometimes. What are the results? Great pain relief. Restoring full range of motion. Most of these people have limited their motion for a long time. I'm not going to get it all back. I can get more motion, but they're restricted. Their muscles have tightened up. They've been tight for 5 years. We aren't stretching those out. We're putting a new joint in. It takes time to get some of that motion. So that's a hard part with the shoulder, getting the stiffness out. Activities, general activities, are about 6 weeks. Main restrictions are going to be heavy weights way out here, huge amount of torque, weights above the shoulder. Those will be kind of the main restrictions. Full activity at 12 weeks, and you'll notice improvement over 6 to 12 months.
How long did you say the PT was?
Anywhere from 4 to 12 weeks. 4 to 12. The knee. Begin your range of motion immediately. This can give, the knee can be good results, but people whine about it longer. It's just got more balancing in it. It tends to ache a little longer. And so, yeah, this is the one that I'll tell people more often at about, 6 to 8 weeks that I did rip your whole joint out and I put a new one in. And yes, it's going to hurt a little bit. It's going to be a little stiff, a little sore. Needless to say, I have people that come in, have full range of motion right off, and they never took anything for pain. So it's a whole spectrum of where you can be. Therapy can be very helpful in getting that motion going. And getting your knee to 95 degrees is really a goal. That's what I want to see, because if you get that around 95, you can start using the stationary bike. It's more of a ease in to getting the rest of that motion, because that repetitive motion can really move those soft tissues along. Icing can be helpful. CPM machine, that's a continuous passive motion. You lie there, the machine moves you. It can be helpful. Insurance doesn't pay for it anymore. That's going to be 50 to 100 bucks a day. We don't really prescribe unless somebody asks for it. What are the results? Usually very good. They can definitely be a little more challenging to get there along the way. And if you come in after 5 years of a stiff knee and you can't straighten it out all the way and bend it, it'll be a challenge getting all your motion back. I don't know who's going to get stiff, but if you do not move a total knee, it will become stiff. So you got to move it. It's not going to be better the next day. Loosening, this is kind of unique to the knees, is people come in with damaged knees. They've been irritated for years and years, and they're stiff, they get swollen, and we replace it. When I replace it, it's stable in all planes. As they start to work it and the swelling and irritation goes down, the tissues tend to relax, and there can be a little rock in them. Now, the majority of people don't notice it. They say it's fine, doesn't bother them. Some people, that rock, it starts to bother them. They feel like it moves a little bit. In that case, we do go back sometimes and change that little plastic piece that's roaming around here. I'll pop that out and put a thicker one in sometimes and tighten it up. It's about a 45-minute procedure. Pretty much you're back to full activity at 4 weeks. It's pretty straightforward. Of course, this is in your total knee, and nobody thinks it's going to be, but yeah, it goes pretty quick. It's about a 3 to 5% risk of that. When do you go back to work? If you're working. Generally, week 1 and 2, I like people to take that time off. It's a lot of energy your body's putting into that joint to get well. So let your body do that. 2 to 4 weeks, it's okay to work from home. 4 to 6 weeks, if you got a short drive, you know, you can do that and sit at a desk. 12 weeks is when people get back when they're working on their feet all the time. It's usually about 12 weeks. Yes?
This is not totally, but did you say that would you recommend that same thing for like a rotator cuff repair?
Rotator cuff? Usually about 12 weeks, they can do that combination there for a rotator cuff. It's a big surgery, but for those full activities, about 12 weeks.
Well, then would they return to work in terms of them not getting capsulitis because they're spending too much time in a static position?
Oh, they got to move it.
That's what I'm saying.
Yeah, a rotator cuff that'll turn to cement too, if you don't do the exercises for that motion. Driving. No driving when you're on the narcotics. Okay? The hip and knee, the right leg, usually 2 to 4 weeks. Generally, I tell people, get out there in a big parking lot, drive, and move your foot from the gas to the brake as hard as you can without hesitation. You'll be ready to drive. But usually that's about 2 to 4 weeks because you have to bend it, and extend, and push. The left leg, once you're able to get in that car comfortably, you can start driving. Shoulder, usually at 2 weeks. You can be in a sling with one hand, use your main hand to power around, and it's actually great therapy for your using that other hand just to let the wheel move it around. Don't go driving like a speed racer though, that won't work out.
I have a question on that. So that was dovetailed from the medication part. Is the person off the medication in 2 weeks?
The narcotics, a lot of people are off them in
So
narcotics.
once you give like tramadol and such, that would be a 2-week stint and then?
Yeah. Yeah, the narcotics would be anywhere from a week, like the tramadol low dose, might be a week to maybe 3 or 4 at the most. We taper it down pretty quick. So, something to remember. You're not going to Les Schwab. We're not just changing the tire and you drive away and everything's just great. Now, I'm working with saws, hammers, chisels, and drills. It's great. There's blood everywhere. It's, a lot of noise. So there is a swelling. There is some reaction. Your knee's going to have some soreness in it, or your shoulder, or your hip. But it's going to be very surprising for the majority of people how comfortable they are. If you start out with a significant loss of motion, you haven't done anything beforehand to get that back, it'll be a challenge to get that motion back. It's a biological system. It was damaged. The replacement will take some time to improve. And you're going to have to put some effort into that motion to get there. So, and then remember, this is what you're looking for. You're not, I can expect this from any of your total joints. If you know how to ski, you're a good skier, you can ski with any of these joints. dancing, walking, cycling, golf. If you start winning at golf, I get 5%. So, and don't forget, not going to make you 30 or 40. You're still going to have some restrictions with it. It's just not going to get there. So these are some of the questions that I've had over the years that are pretty common. How long do they last? Well, I've talked to you about it. You know, and we're seeing them 18 to 20 years. I don't use a femoral block, but I do use an adductor block. I use an interscaling block on the shoulder. Tourniquet time is, for me, is usually between 40 minutes to 50 minutes. And that's for the knee. Closure, staples, zip ties, sutures. That knee that I had up there, that was zip ties. On its tape with zip ties, just like at Ace Hardware. It leaves a great scar. You don't have to have sutures removed, no staples removed. We just peel it off at the end. The CPM, if you're going to pay, therapy as soon as possible. The antibiotic prophylactic I talked about. Post-op x-rays. I usually, when I'm at the outpatient center, I don't take the x-rays post-op. Usually about your 6 weeks post-op, unless there's some question or problem. Hospital, we take them that day. If you had an ACL and you have a bone defect, it'll be fine. We don't take that much bone and we cover it with the plastic. The robotics, the Vellus, the Mako, those are the ones we have up the center up there. I use a different one called a NAV3. Cemented versus non-cemented, that's going to be your surgeon's preference. Bone quality, particular type of prosthesis they're using. How do I size the components? I tend to use a computer beforehand to judge, but when I get in there, we actually size it. We have all the sets, the rep has them in his, with him, and we decide on the exact size at that time. Compression stockings, we use a sequential while you're at surgery. After that, compression stockings, I don't use them that much because it's hard for people to get on. If you're going to use a compression stocking, I usually recommend any of the copper fit type of ones from on Amazon. Put those on. They're easy to put on. They're comfortable. The medications we talked about, what they're made of. Osteoporosis. I can get this stuff to work with osteoporosis, so don't let that scare you if you've got osteoporosis. The surgeries. Any questions?
TSA.
Total shoulder arthroplasty. That's what that is, and I don't remember why I put it up there, but yeah.
My question is about post-op total knees.
Yeah.
Seems like, so I'm a retired PT. Over the years, there's been this great debate about weight bearing.
Yeah.
Not PT, not range of motion, but the weight bearing on the immediate post-op knee.
Right.
You know, the extreme was way back in the 90s, you didn't weight bear for 8 weeks.
Right.
We used to push them, and now you don't push them. I'd like to know your feeling about the weight bearing.
My knee that I did this afternoon, they walked him up and down the stairs before he left. Weight bearing as he can tolerate it.
So it's not a problem long-term with unseating the thing, or, I mean.
It's seated. When I put it in, I'm kind of forceful when I put it down. It's there. It's staying.
It's not going anywhere.
Not go anywhere.
Why were all of those replacements have a rough edge on them?
Do they have a rough? Oh, on the back. The ones that have the really rough edge on the back, that's the bone interdigitates with it. It grows into that one. I don't know if you saw, there's one that's smooth. It might be up here somewhere. Those are ones we cement in. So.
Do you have an opinion on, I noticed osteoporosis is listed there, but do you have any opinion on people taking supplements before surgery to try to strengthen their body?
I generally stay with, good nutritional support. The medications for osteoporosis aren't that helpful for us in the immediate pre-op, post-op period.
I was thinking more about nutritional.
Nutritional, I advise everybody stay on a good multivitamin. You take vitamin C, vitamin D. Some people will go with, vitamin C for healing. That's pretty much it. Calcium is a plus or minus as far as how much it'll change the optimum on the total joint.
After you've had the replacement, is the joint ever affected by arthritis after that?
The what?
Can after you've had the joint replacement, can arthritis affect it?
No, that's gone. The joint's gone. The arthritis is the inflammation of the joints. That's, yeah. TSA, not a total shoulder arthroplasty, it's TSA at the airport. What happens? The one you walk through, bells and whistles are going to go off. They'll pat you down and everything. The one you go into and you put your hands above it, they can see it on their little screen. They may pat your knee, but they can see it. So those are the two different ones. So, yeah, since most of my colleagues were 5 or 10 years old when I started, and everybody at the surgery center is younger than me, I get the questions there, I make some decisions. You guys have any other questions on them?
You know, I do have one.
Yeah.
Do you have any, can you cite any references on the efficacy of the PRP? I don't know that's been studied that much.
Well, it's been studied quite a bit. It's actually, I knew it was hitting mainstream when one of my daughter's friends that works at Kaiser said that Kaiser was using it. That was about 10 years ago.
You pay for it.
But you're paying for it. None of the insurances will ever pay for it because, number one, they don't want to research it and they don't want to pay for it. They aren't going to pay for something that's new like that. I tell you, for tendons, for Achilles tendons, patella tendons, tennis elbow, golfer's elbow, I would do this long before I would do any surgery or anything. And you know, I've had it done probably 7 or 8 or 9 times in different injuries I've had. So, yeah, it's not a steroid. You don't feel better right after it, and you don't feel better the next day, and it will feel worse at first because it's starting an inflammatory reparative stage. You can't take any anti-inflammatories for 6 weeks, which for some people that's like, oh my God, Motrin? No Motrin. Yeah, you can't take that because it counteracts what those platelets are trying to do.
How long is that effective?
It can be quite effective.
How long for what duration? A year, 2 years?
It could be years. If I can get a tendonitis gone, it doesn't come back. Now, I'll do a primary injection, and I do tell people that if it gets some results, you know, I tell them it could be 70% effective. It's actually a little better than that on some of the things we do. But I tell them after the first 6 weeks, if they got some relief, but not quite, they want to try a second, that's okay. But there's no indication, no data that 3, 4, or 5 injections are going to be helpful. So it's 1 or 2, and if it's not helping, probably it's not going to work.
What about ankles?
Ankles?
Yeah.
Joint replacements? Yeah. They don't have quite the durability that these do. They work well, and they have to have specific criteria how they work. They just don't have as much bone or soft tissue support around them. They work well. They do relieve pain. I've seen people come in. I don't do them. It's pretty specialized on that. But the results aren't as consistent as these joints.
Do you ever use PRP shots before hip surgery?
Before when?
Before hip surgery.
I do them if they're putting off surgery for a long time. But it's not going to get the effect of a steroid. Definitely not. I have done it. It is going to be, that is going to be at a surgery center where we can use an x-ray to put it into the hip. I have had some people in their 40s that I did do that, and they seem to do well with it. But if you've got a lot of wear, it's breaking down, it's not going to be as helpful. The synthetic joint fluid, what I talked about earlier, the viscosupplement, that works well in the knee. It's off-label for shoulders and hips. I have used it there, but that is going to be cash pay completely. Insurances won't pay for that at all. So.
What was the percentage that they quoted of the success rate of the Synvisc and Uflexa for people?
Oh, for the joints? Early arthritis, there's 4 stages, stage 2 and 3. It can be pretty successful, 70, 75%. Getting stage 4, it's more of a 50-50.
So if it's working for you, that means your degree was lower.
It'll work with people. I've seen real bad knees it's working with until it doesn't. And it's we usually have to wait 6 to 9 months between those injections if we're getting authorized by insurance especially, but that's the indication. It's usually 6 months or 9 months before you have another one.
Do you do your knees at Folsom Hospital, or do you do it in outpatient?
Both. I'm doing probably 75 to 80% in the outpatient and the rest at Folsom Hospital.
Is
So,
there any advantage to the hospital for the patient?
well, if you've got other medical problems, yeah, because we have other things backed up there. The outpatient, people do really well with it. They get to go home, they're in their own bed when they go home. It's quick, they move you through, it's exceedingly efficient. The facility is beautiful, and so people just feel very comfortable there, and the staff is outstanding.
I kind of like the idea of being watched.
That's it. I get people that just want to stay overnight and,
Yeah.
make sure they're comfortable with it. And that's fine.
The outpatient was right relieving my hip.
Yeah, the outpatient can work really, very well, and people are doing very well with it. And it never ceases to amaze me how well people do with these joints. Every time I do these things and people come in and they tell me how well they're doing with it, it just still amazes me of what we do in there, and people are so comfortable. So.
Okay, I think we need to let it go home. Thank you so much for your time.
Thank you.